Good afternoon. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School, and I want to welcome you to our first leadership forum for this academic year. And so pleased about our guest speaker, Dr. Vivian Lee, who is an alum of Harvard Medical School. You have her bio. I want to tell you a little bit about her, but want to begin with, I had heard about Dr. Lee and wanted her to come as a speaker. But then I had this privilege of hearing her at this national meeting of the AAMC, and what resonated for me was here's this renowned leader in a very powerful and important position, leading a health system and academic institutions who spoke about community and spoke about population health and spoke about service and issues and was able to bring these pieces together with this understanding that as systems we needed to be able to not just address our research and our education and our clinical care, but we needed to think more broadly. And so was doubly pleased when she agreed to come and speak with us this year. She is the Senior Vice President for Health Services at the University of Utah. She's Dean at the University School of Medicine, CEO of the University of Utah Healthcare. Her annual budget is $3.3 billion, much like mine in my office. She's in charge of the healthcare system that has
the world were fair.
that has 4 hospitals, numerous clinical and research specialty centers such as the Huntsman Cancer Institute, a network of 11 neighborhood health centers, an insurance plan, 18 regional hospital affiliates, and over 1,600 board-certified physicians. She has 5 colleges, including School of Medicine, Nursing, Pharmacy, Health, and most recently the School of Dentistry. So very broad sweeping. She is a graduate of Harvard Radcliffe. She was awarded a Rhodes Scholar, did her doctorate in medical engineering at Oxford, and as I said before, she's an alum of Harvard Medical School. Completed a residency in diagnostic radiology at Duke, where she was also chief resident, and also trained as a body and cardiovascular MRI thoracic imaging fellow at NYU. And prior to going to Utah, she was the inaugural Vice Dean for Science and Senior Vice President and Chief Scientific Officer at NYU Medical Center. So the truth of the matter is, if you're in academic medicine, you will have many, many titles. And serve many, many roles because it comes with it. But, and numerous publications. She's been funded by NIH for more than 20 years. So a scholar and academician, but to me somebody who believes in the kinds of things that we've been talking here about equity and social justice that are extremely important and foundational for what we do in medicine. Dr. Vivian Lee.
Well, good afternoon, everyone. It's wonderful to be here today. I really want to thank Joan for inviting me and for giving me the opportunity to get to know her better and the programs that she runs here. I am full of admiration, and I couldn't think of a more important area to focus on than leadership development. I'm going to share with you some of my own perspectives today as a leader of an organization in Utah, and it's sort of an N of 1, and it's really my philosophy about what leaders can do and what we need to do in healthcare. But really, I hope the take-home message for most of you is that regardless of where you're coming from and what your perspectives are, effective leadership and being able to translate your vision and your dreams into actual reality, that's what leadership is all about. And that's why these kind of training programs are critical to our future. So now when I talk about leading the transformation of healthcare, they say if you know one medical center, you know one medical center. So I start with who are we at the University of Utah. But usually when I leave our borders of our little square state, often I know that people in the audience are sort of wondering, like, where is the University of Utah? Or even more simply, where is Utah? Right? I mean, like, oh, geography. So, of course, I turn to the New Yorker as the source of all truth. And so here we have, from the 9th Avenue perspective, we were in New York for 14 years, so, So they got some things not quite right. The U.S. isn't really a square. But they did get right that Utah is west of New Jersey. That's true. It is not really south of Vegas, I'm just going to say, but that's just a minor detail. So anyway, that's where we are. And Joan already told you a little bit about who we are. So we are the only academic medical center for Utah, Idaho, Wyoming, Montana, Western Colorado, and we also cover a lot of Nevada. So that's a little bit different from New York City, where we had 8 academic medical centers. We have a respectable research portfolio, mostly known for genetics, cancer genetics. BRCA1 gene was sequenced in Utah, APC, P16, long QT syndrome, a whole bunch. I'll talk about that a little bit at the end. We are an integrated health sciences campus with a number of health professionals, which I think is hugely valuable at this point in time, given how we're looking at healthcare and transformation. We're a pretty big size for a medium-sized system, 1.7 million patient visits a year, and we've been growing a lot in the last few years. So when we talk about healthcare transformation, this is really, in a nutshell, the problem that we're trying to solve. So you have the last 50 years and the rate of national health expenditures increasing at 800%, which is 51-fold higher than the rate of growth of wages. And that, in a nutshell, is the cost curve that we all are trying to break. And that's really what's made healthcare kind of a bipartisan issue. Now, of course, everyone has different views on how to solve the crisis, but there's no question that there is a crisis that needs to be solved. And the investments, all of you know in this room, don't translate into quality. So when we look at our expenditures crossing $9,000 per person per year in the US, we know that this does not translate into any measures of health outcomes like life expectancy. The US is somewhere between Chile and the Czech Republic in terms of outcomes of longevity, and then in terms of infant survival, again, we are significantly underperforming. So despite this investment, we are on the declining portion of the curve in terms of value. We are definitely not getting better health for more investment. Now, from my vantage point in Utah, and I'm not originally from Utah, so I'm still relatively new there, I think we start at a very good position. So this is one of my favorite slides to show. I especially show this slide when I land in Logan Airport. Okay, I'm just going to tell you, just a little warning. So this shows all 50 states' affordability, so it's healthcare costs per capita on the y-axis. Utah happens to be the lowest cost in the country, in part due to youth, but also lifestyle, obesity, those factors. And on the x-axis, it's the healthiness of the population, and Utah consistently ranks around number 6 or 7. And so when I'm talking to the public about what is value, you know, all this talk about value, 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 this is what value means to the lay public. We want the healthiest population at the lowest costs. And we're starting from a pretty good position in Utah, $5,000 per person per year, almost just a little over half the cost in Massachusetts. But very healthy population here in Massachusetts, so that you have going for you. When we talk about it internally, we define value in this way. For our internal audience, we talk about quality, we talk about the patient experience or the service that we provide our patient, which is very much tied to patient-centeredness, as I'll talk about. And then we talk about how do we deliver those at a reasonable cost. And just to give you a snapshot of where we are at university, I'll just show you one slide on each of these. So these are my bragging slides. You know, my job, brag about the institution, so I'm doing my job right now. If you look at quality, one of the metrics that we value the most is University Health System Consortium, UHC. That is a database of all quality and safety data from all the university hospitals in the country. And now there's over 120 now, but when the former CEO of our hospital joined us in 2007, we were about average. We were about ranked 50 in quality and safety metrics in the country. And in 2 years, he brought us to number 1. And that was actually the year I was being recruited to Utah. So that was actually a very important data point for me. Partly the number, but also the ability to increase and improve quality so quickly. It told me something about the organization. The organization was very responsive to the call for change, which is actually very important as a leader. And then for the last 6 years in a row, we've been in the top 10, and only the University of Utah and Mayo Clinic have been in the top 10 for 6 years in a row. On patient satisfaction, I'm going to spend a lot more time on this shortly, but I think we've really demonstrated huge improvements, so that now about half of our providers are in the top 10 percentile in patient satisfaction, and about a quarter of our providers are in the top 1% or 99th percentile or above, and I'll spend a little bit more time on that. And then finally, in terms of costs, here are our costs in red and the national teaching hospital data in blue, and we are really bending the cost curve. And what we're trying to show is that these are all really interrelated, and they can be positively reinforcing. So if you're really focused on patient communication, on engagement, on shared decision-making, on being really patient-centered, it leads to higher quality, and higher quality with fewer complications, shorter length of stay, fewer admissions leads to lower costs. And the goal really is to get on that virtuous cycle and sustain that. So my goal now is to tell you a little bit about the road to how we've gotten there and some of the lessons that we've learned. And we're going to start with this physician engagement piece, because while the holy grail is patient engagement, I think in order to get to patient and community engagement, you just have to have your physicians on board. If your physicians aren't on board, it's just almost impossible. So I'm going to start with some stories about physician engagement and the transformation. And I think the first case study that I'm going to tell you about is on patient satisfaction. This is an algorithm for change that would be from any change management course that you might take in a business school. So there's nothing really radically new about it. I just adapted it a little bit to our case study here in healthcare. You have to communicate a need for change. The teams actually have to be very different from our standard siloed divisional administrative teams. They actually have to be very interprofessional and interdisciplinary. Big need for data, which we're missing in many areas. And then engaging patients, engaging staff, huge emphasis on transparency, as I'll talk about. And then empowerment for the change, and then continuous innovation. So we'll go through this. So this story around patient satisfaction at the University of Utah started in 2008 when my predecessor, Loris Betts, just got fed up. He got fed up with all the letters of complaint from patients that were stacking up on his desk. Why did I have to wait 14 hours in the ER? And why did the clinic run so late? And staff were rude. And then finally, his wife came into the system. Her last name is also Betts. His name is Betts. Her name is Betts. You think they'd have a clue, but no, she did not have a good experience. Okay, so that was the straw that broke the camel's back. And so he pulled in a group of people. He pulled in the leadership, had an emergency retreat. So I'm told. I wasn't there at the time. And he said, you know, medical care can only be truly great if the patient thinks it is. Like, we all think we're great, but unless our patients think we're great, we're really not great. And he launched us on this initiative to create the Exceptional Patient Experience, EPE, Exceptional Patient Experience. He said, I want every patient to come out of this system feeling like they just had this exceptional experience. And in order to do that, we did a lot of training. We actually went off and studied a lot of different other businesses. And one of the factors we realized is we had no data. All of our physicians thought that their patients loved them, right? Have you ever asked a doctor, do patients love you, and have them say no? So they all thought they were doing a fantastic job. But in fact, we really didn't have much data. So we created a questionnaire. And now we're surveyed to death, I know. But in 2008, this was pretty kind of early, pretty kind of new. So we pulled these questions, and we asked our patients to answer these, scale them on from 1 to 5. And the questions were very important. We focused on things like concern for the patients, inclusion in decision-making, on clarity of communication, instructions, and so on. And we also asked about wait time. Now, these questions we pulled from the Press Ganey database. And the Press Ganey database has over 100,000 physicians, about 140,000 physicians in it. So they have data on how patients scored these doctors all over the country. So you can take a raw score of, let's say, on average, 3.5 out of 5, or 4 out of 5, or 2 out of 5, and you can convert it to a percentile and say, okay, your average of 3.5 out of 5, that makes you about 30th percentile compared to all other cardiologists in the country. Does this make sense? And so we fed that data back to each of the providers. These are each of the questions that were asked. And this is a typical result from, say, a brand new cardiologist who joined our system in 2011. And what we really did is we tapped into their inherent competitive nature. We helped by color coding these. Okay, so red, not so good. And then you could see consistently among our providers this improvement. So that over time, we saw that in the beginning, while they were not performing so well, we gave the data privately. And then we found that it was even more effective to make that data more and more transparent. So after a few months, you could see your own score. Maybe it was getting better, maybe it wasn't. But then you could start to see how you were compared to all the other cardiologists in the practice. Then we would post the scores sort of in the hallway with everyone's names on it. And then the cardiologists could see the OBGYN scores, could see the orthopedic surgeon score. So we made it more and more transparent. And then finally, in 2012, one of our surgeons came to me, or came to the chief medical officer and then came to me, Courtney Scaife. This is in early 2012. A friend of hers said, you should Google yourself. So she's one of our great general surgeons. She's fantastic. So she Googles herself, and the first hit is a website called Vitals, vitals.com, and it's a physician review site. She has 3 reviews, 2 comments, and they are scathing. They are like, this woman has no compassion. She's only in it for the money. She doesn't care about her patient. I mean, it was horrible. And she said, I have hundreds of these reviews. I've been getting this data for the last 4 years. Why don't we post these online? Because at least these are from real patients. Whereas Vitals, your neighbor gets mad at you, then go in and say you're a terrible doctor. So, or an ex-boyfriend, whatever. So we did that. And in 2012, we decided to post all our scores online. So if you go to our Find a Doctor feature, like all systems have this, and you enter her name, and you will see these familiar 5 yellow stars, because it happens to be the surveys from 1 to 5. So we made it familiar, like Amazon and Yelp and everything. And so those are the average scores that she has from all of her patients. And if you scroll down on the page, you can see the individual average scores for each of the questions. So she does pretty well on almost everything. Wait time still needs a little work. And then if you scroll down further, all the patient comments are posted. We post them all. We probably maybe hold back a handful a year that our lawyers think are libelous. Otherwise, they all go up. And the impact on that, on this whole journey of increasing transparency and data and feedback, is shown again in this slide that I showed you originally. So if you see here, in 2009-10, if you look in orange, it's the percentage of our providers that are in the top 10 percentile. So you'd expect about 10% in the top 10% in the top 10 percentile, and you'd expect about 1% in the top 1 percentile. So in the beginning, we were kind of average. And then you can see over time, especially once we went online, a significant improvement. So that now we have whole clinics where every provider in that clinic is in the 99th percentile. Now, when we take down this website for upgrades or whatever, we get complaints from our physicians. They call up and they complain because this is a huge source of referrals. Right? If you're a patient looking for a provider, even if there's some negative things, I keep telling the docs, the negative things are what make it real. Right? Otherwise, it doesn't even look real. So a huge source of traffic for us. So we wrote about our experience, this whole story, and how we implemented this last year or earlier this year in academic medicine. And we've been sharing with a number of other systems so that, and this is a very Utah thing to do. I don't think we would have done this in New York, but we've been sharing with everyone how to do this, and we're just delighted that people have embraced this transparency. So given that story of how we really approached the S component, you can imagine the same principles apply to quality and costs. Getting the data to our providers kind of in a validated way, and then allowing our providers to take that data, figure out how to adapt their practices, and then use a little bit of data transparency to stimulate a little bit of competitiveness. I'll say that on the patient satisfaction story, we had no financial incentives. So all of that change that I showed you, there were no bonuses, nothing financial. It was really purely based on the data and the competitive nature. So if we take the other components, this is my second case study in this section, which is on how we develop the tools to measure quality and cost and to fold that together with patient satisfaction. So when I started, there was a lot of conversation about value. I started at Utah in 2011. I came up through the research side, so I was pretty good at grants and managing that stuff. Didn't really know anything about payment reform. And everyone was talking about value, value. So I said to my team, well, where's my value tool? Where's my tool that shows me value, which is what I'm supposed to be held accountable for? And I said, well, what do you mean by that? We don't really understand. I said, well, where's quality against cost, right? And why don't we have this for every one of our providers who's supposed to be delivering value? And they said, well, you know what? We have a lot of quality data. We have measures out our ears on quality. But cost data, we don't really have at the individual physician episode of care kind of basis. And at that point, I thought, oh, my gosh, where have I landed? How can these guys run this business with no cost data? And then I read this piece by Bob Kaplan and Mike Porter. And they basically talk about this situation. They say, for a field in which high cost is an overarching problem, that's healthcare, like all of our fields, the absence of accurate cost information in healthcare is nothing short of astounding. I think that kind of summarizes it, right? So at that point, I said, oh, phew, it's not just us in Utah. It's like the whole industry. Great. So we set about on a project to really try to cost out at an individual actionable level the cost of care. And I will say that all systems know their overall costs. At a macro level, we know how much we spend on labor and supplies. But very few have actually broken it down to the individual level. And this is a project that brought together informatics, biomedical informatics faculty, our IT people, decision support people, our finance people, a lot of our departmental administrators and faculty. And has taken us a while to really build. But essentially, it allocates expenses into functional areas like labs, supplies, pharmacy. And maybe this slide probably illustrates the best what it does on the costing side. So here is an example of a patient who comes in for an appendectomy, and then we're just trying to figure out what did it cost us to do this appendectomy. And before I show the slide, let me just make one thing clear, because sometimes I forget this, which is that I'm not talking about charges. Okay? I'm talking about what does it cost us as a business to provide this service. So a lot of the controversy around money in healthcare is around charges. Why is a Tylenol $50 or whatever it is? That is a whole separate problem we can talk about. But I think underlying that problem is that we don't actually know our true costs of providing the service. And we are the only industry, that's what Kaplan and Porter are saying, we're the only industry in the world that runs without knowing our true costs at the individual saleable unit, like an episode of care. So that's what we're trying to do. So here, if you take this patient who came in for an appendectomy, let's say they're a little bit of a complicated patient, they have other comorbidities, so they had a longer stay than usual and a little more complicated stay. We actually have costed out labor, supplies, imaging, pharmacy, lab, other services for every unit. In the ER, a minute in the ER, a minute in the OR, on the floors. And if you add that all up, you have the total cost of providing patient care for this one patient. So we've done this now for every DRG, every ICD-9 or 10 code, every patient in our system, inpatient or outpatient. Everything is now costed out for us. So if you have this total cost of providing patient care data for each patient, what you can do is present it to the providers and say, okay, let's look at all the orthopedic surgeons for a particular category of patients and start comparing all of our providers in terms of how much it costs them to deliver care with the same outcomes. Okay? So we have quality data on everybody that shows our quality data is pretty comparable. But if we compare our costs, this is sort of a typical chart. So here are the cost data. This is the first thing we studied 3.5 years ago. DRG 470, major joint replacement of the lower extremity. That's hips, knees, and ankles replacements, very common procedure. And here are the 10 orthopedic surgeons. And you'll see that this is the average cost, not what we charged, but what it actually cost us for these 10 different surgeons. And you'll see immediately there are these two outliers, and it turns out that one of them does ankles and the other one does sarcoma patients. So they're outliers for a reason. So if you exclude those, the other ones are all what I refer to as just bread and butter hips and knees. Okay, some of them are redos. I mean, we're a tertiary academic medical center, so they're not all just first-timers. But they're pretty similar patient populations across those other 8 surgeons. And each of the color components corresponds to the different sources of costs. So in some cases, it's the length of stay. In some cases, it's the OR time. Some cases, radiology. And even from the back of the room, you might make the same observation I have every time I look at all these data, which I look at quite frequently, which is the only constant is the variability. Show me one bar that looks the same across all of those 8 surgeons. And this is one of the most straightforward procedures that we do. So what we've done is given this data back to the orthopedic surgeons and said, what do you think about this data? And what they've needed are some skills and tools that we don't really learn in medical school or residency around processes, around process improvement, around operations, sort of lean type work in industry. And so we partnered this value-driven outcomes rollout with a lean rollout, a training program that we developed in conjunction with our business school at Utah, and have trained up now hundreds of physicians and their teams in lean, which basically enables them to say, why is there so much variability? And they kind of sit in the room, they have this little post-it note exercise, and they say, well, I've always ordered this pre-op, blah, blah. Why do we do that? Is that really what's in the evidence-based medicine or in the recommended guidelines and so on? So using this and implementing this has given our providers the opportunity to monitor quality and monitor cost as they're making these changes using this tool. So this is a complicated slide, but I'm going to take you through it. This shows you the results. We have the most data on this because we started this first in 2012. And what you see here are there's 2 blue lines, and then there's a red line. So I'm going to focus on the light blue and the dark blue lines first. These are quality. Red is cost. So these are quality. And what happened was we actually set up we have 2 phases of our quality metrics. And the first one we call phase 1, and the second one we call phase 2. Okay, so phase 1 is shown here. And what this reflects is the percentage of our orthopedic surgery cases that met an overall quality index that we called perfect care. So as you're trying to think about cost and reducing variability, the easiest target is to have all the physicians thinking about quality. And when we started to roll out quality, there are all these quality measures that are imposed upon us by the payers like CMS. And some of these, we talked about this last night, some of these correspond to quality, but some of them maybe not. Like, did the Foley catheter come out within 48 hours after surgery, the urinary catheter? Okay, for a brain operation, yes, you don't want them to get a urinary infection, but that doesn't necessarily correspond to does their brain work or those kind of measures. So what our surgeon said was, okay, we will accept the quality measures that you inflict on us because we do want to get paid, and we don't want them to get infections. That's important. But let us also introduce some measures that we think are good predictors of outcomes and quality. And so we combined those into a weighted index, which they named in orthopedic surgery the perfect care index. And if a patient hit all of them, they got a perfect index score of 1, and if they didn't, they got a 0. It's just a binary outcome. And so this shows you the percentage of our patients baseline before we implemented in the dotted lines, and then once we implemented in the solid line of hitting perfect care. Now, once we got to around here, some of the measures, like one of them was getting up and out of bed the day of surgery, we were just hitting 100% of the time. So one of the themes in quality improvement and process improvement is it's a continuous thing. So we dropped that as a measure because we were hitting at 100%, and we introduced some new quality measures. So that started this blue solid line, where again, when we added these new quality measures, we weren't looking so awesome anymore. And so gradually over time, that's improved. Am I making sense? So as you see over time, quality improvement, redefining the quality metric to make it a little bit more stringent and tough to achieve, and then that again continuously improves. The surgeons are seeing these weekly. So they're kind of seeing how they're doing overall in perfect care weekly. And then in red, it's the cost. So the overall reduction in cost, about 10 to 15% in cost with this. So this is an example, and it's one of 3 cases that we just published today in JAMA, where we talk about the first implementation period in VDO. And I'm really happy to show this slide. You're the first audience that get to see this. They said it's embargoed. You can't even whisper about it. I said, oh, my goodness. OK, so anyway, it just came out today. And consistently, what we're seeing is that just by giving the data back to our providers, we see about a 10% reduction in cost without changing anything in our system. No epic redo, no nothing, just rolling it out, letting people see the data, and just low-hanging fruit sort of stuff. That's kind of the, now you don't even need to read the paper. And the quality metrics are all up as the costs go down. And what we've learned from this, so both of these stories around whether it's on the patient satisfaction work or the costing and quality work, is something that I just want to kind of summarize the take-home message about physician engagement here. And it has to do with, oh, I lost my reference. I am referring here to Daniel Pink's book, Drive. And I'm using Daniel, you know what I'm talking about? Raise your hand. OK, if you don't know, you should know. So Daniel Pink talks about intrinsic drive and how do you motivate people. And he has 3 elements. And I use his framework to basically digest what we've learned about engaging physicians through these 2 experiments we've done. So he says there are 3 pieces. First one is purpose. So you have to engage in people's sense of purpose. And I think this is actually a given among most physicians. Most physicians have a very strong sense of purpose. We've come into healthcare wanting to do good, to alleviate suffering, and more recently to fix healthcare. So I think that's kind of OK, check. The second one that he talks about is autonomy. And I think this is often forgotten. So an autonomy really applies to physicians. Physicians don't like to be told what to do. They like to be autonomous. They like to see the data and then come up with the solutions themselves. This is a fundamental principle that is often, I think, misunderstood as all these regulations and things are imposed on physicians. And so giving data to the physicians, like the patient satisfaction data, like the quality and cost data, and saying, you figure it out. Maybe we'll help you a little bit. We'll facilitate it a little bit, because maybe you don't just know. But we'll help you a little bit. We're not going to tell you how to do it. I think that's been a very key component. And then finally, mastery. So physicians as a group have been selected. Physicians, PhDs, we're all high performers. We mastered organic chemistry, sort of. We mastered, anatomy. We mastered. And there's a profound sense of satisfaction among most physicians at mastering something. And in particular, we've also selected for another trait that is tied to this, which is that most physicians like to outmaster others, right? Don't like to be bottom of the class, don't like to have the red 30 percentile scores. Everybody really wants to be top of class. And so this really, I think, it's a little tongue-in-cheek, but it's sort of true, that the data transparency just plays to that. People want to feel good, and they want to master it, and then they also want to show that they have outperformed. Everybody wants to do the Lake Wobegon thing. So when you take all these things together, now we've put this video tool now in the hands of our physicians and our health system leaders, and I'll give you kind of an example of how it all plays out. So here are these 2 guys. Sam is the chair of surgery. We actually got him from Atul Gawande's group. And Rob Glasgow is his vice chair of operations. And I run into Sam, and Sam pulls out his iPad and says, I have to show you this. We have this video tool. It's on your iPad. You can look and compare yourself in terms of your own cost and quality outcomes as a surgeon against all the other surgeons. And he is a laparoscopic surgeon, so he's showing me this data. And then he kind of hones in on this new chart that they've created, which looks at OR costs. And so this is supply usage in the OR for laparoscopic laparoscopic cholecystectomy. We have a bunch of surgeons who do this. And I said, oh, great, Sam, where are you? And he said, well, this is Rob, and that's me. And I said, oh, Sam, number 2. That's pretty good. And he said, no, I have a plan, Vivian, I have a plan. There's this balloon dilator that I use, and Rob's been telling me I don't need to use this. I trained with this, and so whatever, I haven't been. But if I get rid of that, and he's going to teach me, if I get rid of that, I'm going to be the lowest cost. And the outcomes are all pretty comparable, so I'm going to be the highest value provider. I said, good job, Sam. So walk down the hall, and I run into Rob. And I say, hey, Rob, I hear Sam's dropping the balloon dilator. That's all I said. He looks at me, he's like, yeah, I know. He knew exactly what I was talking about. He said, yeah, I know. He said, but you saw the variability, Vivian. I, as the vice chair of operations, which is what he was, I'm going to get that variability down. And then who's going to be the winner? I said, you are, Rob. You're going to be the winner. So that, I think, in a nutshell, is the story of what we've learned about physician engagement. And that's the bulk of what I want to tell you. I'm going to spend just a little bit of time on these other 3 points because I think they're also, from my vantage point, absolutely critical. So patient engagement, we could spend hours talking about patient engagement of the community, and how we really move the dial there. I'm just going to tell you one example of how we're thinking about it. And that is really in terms of defining value. One of the things that I have found very frustrating as someone still pretty new to this is we define value or quality really in terms of what the payers think. That's how the quality measure, and maybe now some of the professional societies. But we really don't define value in terms of what patients think is valuable, because the quality measure completely ignores anything about what patients think, except for maybe a tiny thing on patient satisfaction, but very small. So again, our orthopedic surgeons leading, I have to stop calling him boneheads now. I have to cut that out of my language, because they're really, our orthopedic surgeons are fantastic. They started 2.5 years ago implementing patient-reported outcomes. They put these iPads in all the waiting rooms in our orthopedic hospital and used the PROMS system from Northwestern, adapted it. It's a series of questions that you can do on your iPad or on your phone or at home before you come in. And this was ARC and NIH funded, and I think many of you may be familiar with these. And they really ask about quality of life with respect to physical function, psychological well-being, and social well-being. And so here's some, for those of you who haven't seen it, these are some of the questions about, say, physical function. And it's computer adaptive, so once you kind of indicate where you are generally in the spectrum, the questions are smart and kind of, it reduces the amount of time that the patient has to spend asking the questions. And at the end, it gives you a number for each of those categories of physical function, psychological, and social well-being. It took us 6 months to break through the barrier with Epic to actually get the data into Epic. That was the big success story of the first year. And then now we've expanded it so that it's accessible in a number of different portals. And this is an example of what we can do with this data. So what we're really trying to do here is have patient input in terms of our measurements of outcomes. And it's just a first step. It's not comprehensive, but at least it is a first step. So here's one. This is hypothetical. We have not done this. Okay, this is hypothetical. But when you think about what would you do with all this patient-reported outcomes data, one is to guide decision-making. So, for example, if you have a 50-year-old male who has a BMI of 35 or over and is coming in and thinking about what to do about their bad knee, and some choices include doing nothing, arthroscopic surgery, physical therapy, or knee replacement, what you could do is look back in your database and say, for patients who are like you, this is generally what happened over time. And these are the kind of choices that you have as a patient in terms of thinking about the course of your care, for example. Or after you get your knee replacement, here is how you are in red compared to, say, how other patients like you have performed. Another area that's been, some foundations are very interested in, is the degree of psychiatric information that we have, mental well-being and depression screening. In the first year that we rolled this out in the orthopedic hospital, we had 65,000 responses. Over 95% of our patients complete these. And so for the last, this year and the coming year, we're rolling it out across our entire system. So we plan to have all of our patients, regardless of their indication, coming in and answering some patient-reported outcomes measures and adapting some of the quality of life questionnaires for specific disease groups and cohorts. So that's kind of one direction that we're trying to take in incorporating the patient voice. And probably just as big of an impact has been really liberating our workforce to be thinking much more about what they can do for patients. I have 3 examples of initiatives that one clinic started in the last year that I think really represent this much more patient-centered mentality. In one clinic, we started in-clinic childcare. So this is a clinic. It's about 220,000 square feet. It's in a neighborhood of a lot of young families with kids. And we did a little business plan that showed that if one woman a month decided to have their next baby at the University of Utah, this clinic paid itself because it's tiny and it has one staff, and the other staff person is a student in the education program of the university, so they're free. You can drop your kid off. You have to be seeing a doctor or somebody in the clinic, and you can't leave the premises. I'm sure it's tempting, and no more than 4 hours. I'm sure that's tempting too. The second one is in-home newborn visits. So, it's 7 days and 14 days when you have to bring your baby in. I had my babies in New York City in the middle of winter. Like, how many taxis will stop for you with a baby? So I have, like, PTSD when I think about this. And then you get into the waiting room, and you got a waiting room full of runny noses, and you're thinking, what am I doing bringing my baby here? So our pediatricians have really advocated this. A nurse and a pediatrician, they hop in their little Prius, and they drop around the neighborhood, and they visit the families. Very important for also reminding the families about, don't shake the baby kind of prevention measures. And then one-stop shopping clinics, so particularly targeted towards women who make most of the healthcare dollar decisions but don't tend to look after themselves so well. Labs, mammo, paps, all in one morning, very coordinated care. I'm very proud of this because I think it reflects a culture of patient-centeredness within the organization that is not around my office or the C-suite, but really kind of at the grassroots, and that we have a culture that really embraces these kind of innovations. Okay. Now, once we do all this, one of the things that I feel is so important for us as an academic institution is that we are responsible for the workforce of the future. And so a lot of this is about sustainability of the change. And when I think about the future, I look at my medical students and I think, oh, okay, we've got an interesting mindset. And how can we take advantage of the trends that are happening? So one of the things that I realized when I do these town halls with each of the medical school classes, one in the fall and one in the spring. And so in the spring, or a year ago, I guess, I asked this question. I said, how many of you remember life before people were talking about healthcare reform? Like nobody. Because they were born in the 90s, right? So they were in kindergarten or pre-K when Hillary was going through version 1 of healthcare reform, right? I'm saying they, I'm looking and seeing some of you in the room, but you know what I mean. But anyway, so how many of you remember life before Google? None of them. Okay, none of them remember life before Google. And then I asked, the worst question for me was, how many of you think Mark Zuckerberg is kind of old? I got like 2/3 of the room, because these are in the 20s and Zuckerberg's in his 30s. I said, oh my goodness. So, but what I have come to realize is that so much of what we need to do going forward comes second nature to our trainees. So this transparency of the patient satisfaction scores and posting that online, like Yelp, heck, of course. And so we just started the pilot project for our residents. And not a squeak. Nobody complained at all. Nothing like the physicians. It's sort of a given, right? Patient-centered, customer-centered, of course, they understand that completely. Very much about data-driven, very much about interprofessional and team approaches. And so what we've been trying to do is to create an environment in the university that really taps into that and says, instead of complaining about the millennials and the trophies and blah, 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 all this stuff that people like me sometimes complain about, why don't we tap into what is uniquely a part of this generation? And one is innovation. There is just so much drive for innovation. A lot of it is around technology or around online, around apps. So these students started a bench-to-bedside competition in 2010. Last year, there were 44 provisional patents filed from these student teams that include medical students, engineering students, and business students, MBAs. Tap into that, And then I told them, when you guys go, my MD PhD student actually sent me an email at Christmas and said, Dear Dr. Lee, I just wanted to let you know I sold my first startup. And it was an online wedding invitation thing. It had nothing to do with medicine. Then he wrote, because he started before he came to medical school, and then he wrote to me and said, and I really hope my next business is in healthcare. And I said, I do too. And then remember where your roots are. We can name a whole building after you, no problem. So we've been really tapping into that and partnering with our business school to really fuel that. We have a master's degree, and every year several of our students take time off just to do that and do their companies. and a big focus on gaming, video gaming, and app development as part of that innovation. And that's just one example because I don't have enough time to share with you. But I think thinking about the sustainability of change through the lens of the trainees and the mindset of the people who are coming through the system, I think it's going to be very, very critical for our success as academic medical centers. I think of that as the education piece, and here I'm going to talk just a little bit about the research piece very briefly, just to say that just as important as everything that I've talked about so far, we really have to think very seriously about how we leverage science in healthcare transformation. And I particularly want to talk about how precision medicine will drive value. We are at this intersection of precision medicine, Francis Collins, Barack Obama, everybody's saying, yes, let's sequence the heck out of everybody. And then on the other side, we've got Secretary Burwell and Pat Conway saying, but you are now going to take financial responsibility for everybody. And I feel like we're just kind of right, those two trains are just going to they're just going to crash. Like, we need to make sure that the money that we spend in precision medicine is going to drive value in healthcare. Okay, otherwise it's just going to, the bank is already broken. So this is a very important issue for us, and we've been thinking a lot about this at the University of Utah. We have a very special resource in these enormous families that we have in Utah as tools for identifying genes. We have this database called the Utah Population Database. This, by the way, is one man and his immediate family. But this is where, you know, I joke about it, but actually polygamy is a geneticist's dream come true. Because, you know, when you're looking for genes, it's actually very, very powerful. That's what they tell me. So I can't really speak about it firsthand. But anyway, so the Utah Population Database is the world's largest database of its kind. It was created 30-some years ago with the genealogies from the Mormon Church combined with the medical records from the University of Utah and from Intermountain, Department of Health, cancer registries. It has about 7.5 million unique lives. The next largest database of its kind is the Decode Icelandic database, which has about 500,000 lives in it. And that database was bought by Amgen for $450 million, just to give you a sense of the value in terms of drug identification, as well as diagnostic testing. And so as a result of this database, and the people come from all over the world, genetically actually quite diverse in this database. And what it enables you to do in very small numbers of families is to basically, unlike GWAS, where you have 1,000 people with and 1,000 people without, you can do a much smaller genetic discovery studies with these families, affected, not affected. The rest of the genes are actually pretty similar among family members. And this is an example of the pedigree that was used to find the APC colon cancer gene. Over 30 disease-causing genes have been identified across a wide range of diseases. And the potential down the line, which is where we're trying to have the value-driven outcomes tool intersect precision medicine, is looking at whether it's developing safer drugs or the value of earlier cancer screening and prevention to pharmacotherapy and more precise drugs. And in all of these areas, the standard that we need to hold the implementation of precision medicine to is that we are really always making sure that we're measuring the impact on quality and outcomes against the actual costs. I'm just going to say that is so important. So I'll just close with these last two slides by saying that I think that frequently those of us who are in academic medicine think about our clinical enterprise and then our research and education enterprises independently, and sometimes we think about research and education as almost burdens to us. You know, we have to go subsidize those guys, we have to go feed the researchers, you know, those kinds of things. But in fact, I hope that you get a sense from the various examples that I showed you that really the academic mission should be viewed as our competitive advantage. And the more that we think about our trainees and students as the source of innovation and the source of inspiration and the connection to our patients and our research, again, also being able to drive that change and make it scientific and disseminatable, the more effective our clinical enterprises are going to be. And so with that, I just want to thank you very, very much for having me here today.